Thank you. So this first talk we'll have here is going to be on the do's and don'ts. As I mentioned, this will be a little change from the program that you saw there. Foremost, by conflicts of interest, I have nothing relevant to this talk and nothing financially related. And I should thank Cyril for putting together this symposium. As I mentioned, as we move in 2014 forward, turns out that surgical safety is going to be the most important thing and what we're judged on. In North America, now this information is published, so patients can go to a website and see your complication rate, what you do in surgery, how well your results are, and pick their surgeon and reimbursement based upon this type of information. I think the way I've structured my talk is the way I think about patient safety and the things to do and not do, and we'll focus in a fashion like this where we'll talk about preoperative, intraoperative, and post-operative do's and don'ts to keeping your patients safe. Now I'm a hip and knee arthroplasty surgeon in addition to a tumor surgeon, so I'm going to structure this primarily around a reconstruction type feeling, but these principles apply to any specialty and any joint within orthopedics. From a preoperative standpoint, there are multiple things to consider, but I think this one slide sums it up. The majority of failures are a failure of planning. So the vast majority of your surgery, the vast majority of my surgery happens outside the operating room. It happens picking the patients appropriately, making sure we've planned correctly. I've thought about the surgery myself, and then we execute it. So a vast majority of these failures are going to be related to failure of planning. So what can we do and not do to avoid this? Now, we always leave the history to the most junior doctor, in our case, the medical student, but I think this is probably the most important thing in orthopedics. It's important to understand your indications. I get a lot of people referred to me for a painful total knee, and it turns out that the knee is done perfectly. It's actually that they didn't have arthritis or debilitating pain before they had the surgery. So it's a failure of the indications, and there's no surgery that can correct that once that occurs. So you need to make sure that your indications are clean, patients have true debilitating pain, and that you've failed conservative management. The second thing, which I cannot underemphasize, is a patient's past medical history. You have to understand their comorbidities. In the hip and knee arthroplasty world, diabetes and obesity, in addition to inflammatory diseases such as lupus and rheumatoid, are very important considerations in the management of these patients. Surgically, the vast majority of patients that we get referred have had previous surgical intervention. This could be a simple arthroscopy, it could be a reconstruction, it could be an osteotomy, or it could be another arthroplasty. You need to know what previous surgeries that person had and when they had them. In my clinic, I mandate that patients bring their old operative report. I want to know what the other surgeon did or saw before we do a reoperation. And it's important to have that because if there's hardware in place, it tells you what type of hardware is there when you need to remove it. What about medications? 2014, a host of patients are coming to your clinic on high-dose narcotics. Some are immunosuppressed, particularly in my practice. We take care of a lot of people with kidney and liver transplants, and others have significant blood thinners from the rampant cardiac disease in the world. These are all things you have to manage as a surgeon. So if you stop an antiplatelet medication and the stent thrombosis, that's a big deal. If you operate on a patient with immunosuppressants and they don't heal their wound, that's a big deal. So these sound like small things, and we let the most junior doctor address them, but these are the things that are going to get you into problems. What about patients with allergies? It's becoming clearer to us from the literature that penicillin allergies are overreported. Everybody suspects they have a penicillin allergy because their mother told them that. So we have a clinic now where they get a skin test to test if they have a penicillin allergy. In fact, the rate is much less than 1%, and the vast majority of these patients do just fine with a first-generation cephalosporin. Finally, social history. Patients who smoke and or use illicit drugs is important to know. It's important to me and my surgical team if a patient has IV drug use, history of hepatitis or HIV, I need to know that because it changes how we do the surgery for these patients. What about the physical exam? This is something I do for each patient myself when I see them in consultation, and I do the day before surgery. I see all my patients at least twice. So it's important, regardless of your specialty. These are knee cases, but you need to identify previous incisions. This is a lady I did last week, 17 previous incisions all over the knee. You need to know where these are and plan appropriately. You've got to understand your range of motion. No question in the knee that your preoperative range of motion is your number one predictor of your postoperative range of motion. So you need to document that before and have a discussion with your patients. What about stability? Stability is an issue in any joint within the body. This is a knee example again. This patient's got significant valgus deformity with valgus laxity. You need to identify that preoperatively because that's how you're going to plan for the surgery. And especially important, and we've talked about this with our medical students, our most junior doctors, is examining the joint above and below. 20% of people who get a knee replacement actually needed a hip replacement. There's a large portion of people who have referred pain. So it's absolutely essential to check the joint above and below. In my practice, every patient gets x-rays above and below. You might not need to do that, but you certainly should examine them. Preoperative imaging. You cannot accept poor imaging from your radiologist. If you're not getting the x-rays you want, you need to meet with them and make sure you're getting the x-rays you need. You cannot function as a surgeon with poor x-rays, and you cannot let the radiologist be your limiting factor. So you need to make sure you're getting the x-rays that you want and they're functioning appropriately for you. In my case, I always get an AP, a lateral, and the patella views for the knee. More importantly, I like to get the long leg x-rays. So this is a lady with significant deformity, and I can't do this surgery without a long leg radiograph. So it's absolutely essential to have your appropriate radiographs before you see your patients. Templating depends on your specialty, but no question in the hip and knee world for arthroplasty, the trauma world, several shoulder and elbow surgeons, that templating is essential. When you think about templating for the spine, when you're placing your pedicle screws, you need to know the diameter of the pedicles, you need to know the length of your pedicle screws at each level before you do the surgery. So templating, regardless of your subspecialty, is absolutely important. Again, this is where I spend most of my time. It's not in the operating room. I'm in the operating room for a very short amount of time. Most of it is in my booth getting ready for the surgery. If patients have had previous infections, hardware, it's important to rule out infection. Very simple. ESR, CRP, if there's any question, and aspiration. Any trained orthopedic surgeon can put a needle into any joint and take fluid out. There's no reason in 2014 not to be aspirating joints that are concerning. So that's the preoperative plan. I'm going to switch into the second third of the talk here, which is intraoperative. So how can you avoid problems during surgery? What are the do's and don'ts during surgery? And I always tell my residents and fellows that intraoperatively, this is a failure of execution. So you've planned appropriately, but you've done something wrong. You have executed poorly. And that's really where it comes down to intraoperatively. So if you've planned appropriately, you need to execute appropriately. I tell them this is like an American football game. You've trained the whole week, and on Saturday, this is the game time now, okay? So you have to come to the game, and you have to be ready to execute. So this is probably the most important thing to me. So this is my team. I operate with the same team every other day, no deviation from the protocol. I have the same nurse, same scrub tech, same resident or fellow, and same assistant. I have the same team. They know how I function every single day. If you have people who are changing in the back table, the nurse is changing, you're paying attention to all the periphery and you're not focused on the surgery, okay? So it's very difficult to do this, but you need to form your own team and you need to operate with the same team each time. The team knows you and you know the team, and this is probably the most important thing to executing your surgery appropriately. What about briefings? This is a big push by the World Health Organization. At the Mayo Clinic, we've adapted this for over a decade, probably longer than that, just the amount of time I've been there. We've always had this. So what I do in the morning with that team is we all meet outside the operating room and we go through each surgery for the day. And I know everything that's going on for the patient, but don't forget my team has never met the patient. So that's the time that I tell them everything about the patient, the nuances. I let the anesthesiologist ask questions, tell them what I expect, and then I make sure that I have the implants. My nurse has all the implants there. I look at them myself, and I make sure that we have everything that I need or don't need, and I have all the appropriate imaging. So we call this a briefing, and I do it at the beginning of each operative morning for the whole day. Separate from that, at the beginning of each surgery, once we're scrubbed in, we do a pause. And so this is the WHO's checklist. And the reason I let it be small still and didn't highlight it is you can't get stuck on this checklist. You need to focus on what works for you, but you need to have some sort of list. So many of you flew here. Pilots have been doing this since 1940. When you get on the plane and everybody's boarding, pilots have a checklist and they check off everything to make sure everything works. It's the exact same thing for a surgeon. You need to have a checklist if everything's ready, and we go through this right before I make incision for each patient. After we've done that, we can move on with the surgery. There are a couple of points I'm going to show here that are generalizable. Again, this is focused more on a knee talk, but these are really generalizable topics to the majority of patients, okay? So intraoperatively, it turns out that using the saw is not the important thing. Protecting the structures. So I let the residents and fellows use a saw, use a knife. My job is I put the retractors in the right spot, and I protect them. It's the goalposts. So retractor placement, in my opinion, turns out to be the most important thing during the vast majority of orthopedic procedures. So for instance, in this total knee here, I let the resident and fellow do what they want, but I hold the two retractors protecting the MCL and LCL. That's what I'm concerned about. I give them the goalposts, and then they just function as a machine. It's really important to protect your structures. That's the key to being a good teacher, to being a good surgeon, is protecting the structures for them. You have to protect the tendon, very similar to ligaments. In an arthroplasty, you can see in this case, they had a patellar tendon avulsion, and it's because of basic retraction and protecting the tendon. This can happen in nerves. In orthopedics, we operate around tendons, ligaments, nerves, vasculature, and bones. There's a lot going on. The same thing here. So you need to protect these structures intraoperatively, and you have to also be aware what you do. So for instance, this person with a significant valgus deformity and fixed flexion contracture, when I straighten them out postoperatively, they have a risk for a foot drop. So we flex them. I check them in the PACU myself. If they're doing fine, we take the bump out. If they're not doing fine, we flex it up and take off the dressing. So these are things you want to be actively aware, and the only person that's really going to worry about this is the head surgeon. So the onus falls on the surgeon to make sure that these things are occurring. What about vascular injury? This is rare, but it's a catastrophe. There's very few things during revision hip or knee surgery that I can't fix, and this is one of them. So you need to be very cautious with the saw blades, particularly in the back of the knee or in the front of the hip. What's more important is if this happens, you need to recognize it and recruit the appropriate person, okay? So this is unbelievable. So in knee arthroplasty, one of the most popular procedures in the world, 38% of people recognized a popliteal artery injury. That means 2/3 of popliteal artery injuries that occur are unrecognized intraoperative. And that's a catastrophe. This is a major artery that's profusely bleeding, and it's not recognized intraoperatively. The wound is closed, the patient doesn't do well, and they return to the operating room. So complications happen. The important thing is how you handle them. And so you need to recognize if there's something that's concerning, you can't stick your head in the sand. You need to recognize it and call your vascular surgeon, and it might not be anything, but it behooves you to take a look at it while the knee is open and you can see into the back of the knee. Don't allow intraoperative fractures to occur. So a lot of us take care of fracture patients. We're trying to fix fractures, not form them. If they do occur, take care of them. We looked at our own series of fractures at the Mayo Clinic. The rate is much less than 1%, about 0.4% intraoperative. But they do occur, and when they occur, you need to take care of them. It's very easy to take the easy way out and put a constrained construct or brace the patient or what have you. A fracture intraoperative is just like a fracture that you're treating from the emergency room. You need to address it. It needs to be reduced, stabilized, and fixed. You're not going to be thrilled at your x-ray that you've got a couple of extra screws next to your primary total knee, but that's the right thing to do for the patient. So recognize the intraoperative fractures and treat them appropriately. This is a hot point I'm going to highlight with an example. So it's important not to skip steps. All of us have a lot of surgeries going on throughout the day. We want to get to the next surgeries equal to skip steps. One of the main problems we see in the knee arthroplasty world is patellofemoral tracking. We thought this was an issue of the 70s and 80s, but it's coming back, and is one simple reason. It's skipping steps. So if you execute a set amount of steps the same way every time for these procedures, things will go fine. For instance, when doing a total knee, you need to lateralize the femoral component and externally rotate it a certain amount of degrees. For me, it's 3 to 5 degrees. If you cut these steps out, you're going to have problems at the end of the case. Same thing with the tibia. For you to get appropriate tracking, you need to lateralize your tibial component, and you need to have external rotation of the component as well. The point doesn't move anymore. Thank you. And the next area is with the patella. So if you're going to do a resurfacing of the patella, which is popular in North America, you have to go through these certain set of steps every time, and you can't skip them or you're going to have a problem. So you need to reproduce your patellar thickness. Measure it before. It takes an extra 5 seconds. Make a symmetrical cut. The way I do it is I make my cut, I draw into 4 quadrants, and I measure each of the 4 quadrants, and I spend the extra time to balance that cut. And then you need to put the components in the right position. So you see that there's a whole host of steps that have to be done to simply get one part of the procedure correct. And it's very easy for you to start skipping steps and at the end of the case wonder why your patella is falling off to the side. So execute all the steps appropriately, and that's going to be in the best interest of your patients. What about preventing intraoperative bleeding and anemia for our patients? This is really a big patient safety push. One of the biggest problems for patients right now is having hypotensive events that leads to medical complications on the floor or requiring transfusions that has a whole host of complications. And there are many things we can do as surgeons to minimize these problems. Probably the number one that's bolded there is surgical technique. It's important to handle the soft tissues very softly. The vast majority of orthopedic procedures are soft tissue procedures. While we're doing a lot of bony work, what's going to determine the outcome for these patients is how you handle the soft tissues, okay? So surgical technique's essential. We can debate tourniquet or not for all you want. Controlled hypotension, blood salvage techniques, hemodilution, and one area I'd like to focus on because I don't know how much it's being used across the world, but it's gaining significant popularity in the United States, is the use of these antifibrinolytics. And these are medications that work after the coagulation cascade. No studies shown an increased risk of venothrombotic diseases, but they certainly reduce blood loss. So in the hip and knee literature, we note that the use of tranexamic acid in many level 1 studies and meta-analyses has decreased blood loss by 500 cc's and an average of 1.5 units of transfusion per patient. So there are a lot of things we could be doing to helping our patients. So at Mayo, we just published looking at giving this medication to our sickest patients. So those patients with ASA4 who have had previous clots, and those patients had a decrease in mortality and a decrease in transfusion from 50% to 8%. So sometimes your sickest patients benefit from some of the smallest things you can do. $4 US dollars for this medication, and you've decreased the transfusion by 40-fold, 42%. So there are significant things you can do, your anesthesiologist can do, by keeping your eyes open on things that are happening in other specialties. So this is very popular in the hip and knee world. We've been doing it at Mayo since 2002 on nearly 95+% of all of our patients. And we have a lot of ASA 3 and 4 patients. So it's something to consider in other specialties. Finally, I'd like to focus this last third of the talk on post-operative do's and don'ts for patient safety. I think the one thing to remember from this is that post-operative complications and patient safety issues are really a combination of factors. So they're poor preoperative planning, poor execution, and host factors. There's no question that an obese patient who smokes with diabetes has an increased risk of complication compared to another patient. So these are a host of factors that affect this. Probably the most important thing is the wound closure. The 2 things I do myself are the exposure and closure. I let the fellows and residents, I'm there, I let them do a lot with the saw, other things. But the closure, I like to do it myself. It's not something to be left to the junior doctor. This is probably the most important thing. You could have done a beautiful surgery, spine, hip, knee, shoulder, elbow, whatever. If it becomes infected, it doesn't make a difference what you did underneath. You've got to restart the whole process. So wound closure is absolutely essential. Watertight seal, maintain your vascularity at the skin. We also know there's an increasing body of evidence that the patient's preoperative nutrition status is essential. I've noted a couple of the basic parameters here. If you have patients who are after bypass surgery, not healing their wound, things like that, you should start considering checking their lymphocyte count, their albumin, and their serum transferrin. Craig Del Valle from the Rush Group has published a couple of studies on this now, and the GI doctors and the general surgeons have done a lot of investigation on this. So you need to optimize their albumin and their protein status before surgery. What about surgical site infection? So now every time I have a surgical site infection, I get an email from the CDC. That's the U.S. Center for Disease Control. Even if it's a superficial cellulitis, they send that to me, and there are multiple things you can do to look at that to minimize it. So skin preparation, skin shaving, antisepsis, operating room environment, surgical attire, your instruments, your duration of your operation, your surgical technique, and your antimicrobial prophylaxis. What's important with your prophylaxis is do not forget to give patients antibiotics within 1 hour of surgery. It's real important to give them those antibiotics within 1 hour of surgery. What about deep infections? For the sake of time, I'm not going to go through all these details, but there are a host of systemic and local factors that affect the risk of infection. Some of them are modifiable: diabetes, obesity. Some are not modifiable. So you have to address the things you can address with these patients. What about VTE? Make sure you encourage your patients to ambulate, have compression devices, and there's a whole host of anticoagulation and chemoprophylaxis. It's beyond the scope of this talk, but make sure you anticoagulate your patients per your recommendations, but also make sure that you're monitoring it. Hematoma and reoperation is a real problem. It's a real problem, particularly in knee and hip arthroplasty, so there are multiple ways you can minimize that. Having a close eye on these patients is important. Postoperative arthrofibrosis, make sure patients have appropriate physical therapy, but not too much. This slide I'll skip. And my final two slides are here. WHO has a very nice article, particularly in 2009, highlighting briefings, pauses, and checklists. We don't use this checklist. We use our own Mayo Clinic one, but this is a good reference. You have to form one for your particular hospital and your particular team. And finally, this is maybe my Mayo Clinic part that I can't resist, is you have to follow your patients. Okay? You have to follow them at consistent intervals. So this was published by Dan Barry in 1997. Our registry is now over 45 years. I looked at it. It's got over 150,000 total joints in it. And we have 90+% radiographic follow-up and 95% plus clinical follow-up at up to 45 years. So it's important to follow these patients. You're going to identify problems, complications, issues if you follow your own patients and your own data. So in summary, I think the way to avoid complications and keep your patients safe is plan your surgeries, execute them, and optimize your patients. There are many factors that include patient, surgeon, and implant factors. Problems occur in surgery, that's fine. The problem is identifying them and treating them as expeditiously as possible. Thank you.